Hello student, we're going to be talking about burn injuries and its management. Next slide. All right, so what is burn? Burns are wounds produced by various kind of agents that can cause cutaneous injury and destruction of the underlying tissue. All right, and so what are these agents we're talking about? The agents that can cause burns include excessive heat, chemical, fire and steam, radiation, and electricity. Radiation and electricity. Next slide. So burns result in about 10 to 20,000 deaths annually. So this is really serious situation. You have a better chance of surviving a burn if you are between the ages of 15 and 45, for the reason that we know that the young are overhydrated and the older people are underhydrated, and individuals that have sensory problem, such as the diabetes, have a lesser chance to do well. The survival rate is best if the burn is not as extensive, so less than 20% of total body surface area. Next slide. So what are the types of burn? Types of burn include thermal, which means there's an exposure to the flame or hot object. Chemical, which means there's some exposure to acid, alkaline, or any organic substances. Electrical, which results from the conversion of electric into heat. It extends of injury depends on the type of the current that is that touches the skin, the pathway of the flow, the local tissue resistance, and of course the duration of contact, how long you're exposed to it. Radiation burn results from radiant energy that is transferred to the body, resulting in the production of cellular toxins. Next slide. This picture shows you a chemical burn. So clearly the skin is impaired. Next slide. This is an electrical burn. There's a significant difference. You see the nail beds, what they look like. Next slide. So it's important for us to assess the wound, right? And generally the wound is classified according to the depth, right? How deep the injury is and the extent of the body surface area. And it's differentiated depending on the level of damage to the dermis and other subcutaneous tissue that are involved. So they classify them into 3 different types: superficial, which is 1st degree, deep, 2nd degree, and full thickness, which is 3rd and 4th degree. Next slide. This is showing you what it means by how extensive the burn is. 1st degree is epidermis, 2nd degree goes into dermis, 3rd degree goes deeper into the muscle. So clearly the deeper it is, the more serious the issues are. Next slide. So let's talk about each of these degrees of burn. So the epidermal tissue is affected only in the 1st degree burn, like I mentioned. And when you assess it, what you see is erythema, there's blanching on pressure, there's mild swelling, and there's no vesicle, right? It's usually not a serious type of burn, unless the area is pretty large. An example of 1st degree burn is sunburn. So the summertime, you see a lot of folks who are out there laying, and sunburn is usually typical for that. Next slide. And this is a picture showing you also the characteristic of a superficial burn. So you see the normal tissue and the epidermis is what is involved. And the top is the zone of necrosis and coagulation. And then the edema layer, so the swelling occurs, and then the injury of stasis. So with the superficial burn, there's usually a small zone of injury, right? So it's not as deep. So there's a small zone of injury, but definitely the zone of necrosis is usually affected because it is the upper third of the dermis. Okay, next slide. So this is an example of that. Next slide. Next slide. So now we're talking about second degree burn, which involves the epidermis and also deeper layer of the dermis, right? Epidermis and deeper layer of the dermis. It has fluid-filled vesicle, right, that are red, shiny, wet, and there's lots of pain, all right? So first degree, there's also pain. Hospitalization is usually required if it's over 25% of the total body surface area. And we're going to talk about how to measure the percentage of burn. An example of second degree burn occurs with tar burn and flame. Think about individuals who live in homes, elderly that lives in one of these bigger homes who fall. That situation happened once where the neighbor fell in our tar driveway, and it's during daytime, most people at work, and she was on the floor. She couldn't get up, so she suffered an extensive burn from the tar. You also can have a second degree burn from flame. All right, when you come in contact, the skin comes in contact with a flame. Next slide. So these are the characteristics. Of course, the zone of necrosis is more extensive, right? There's, of course, the zone of injury that is also involved, but there's smaller edema layer. Next slide. So look at this. It's absolutely not a good sight. Next slide. So I need you to think as you're looking at this slide, what are some of the issues that you're going to be addressing? You see the nail beds are blue, so there's tissue perfusion issue right there. It's open, fluid deficit, infection, self-body image disturbance, anxiety. So there's many issues that you should be thinking about when you look at someone's that is burned as such. Next slide. So full thickness or third degree burn is the other layer of burn. So here what is happening is there's this destruction of all the skin layers, all of them. So of course it requires, because it's deeper, it requires immediate hospitalization. And usually when you look at it in your assessment, you find that it's dry, waxy, white, leathery, hard skin, and generally there's no pain here because the nerves have been destroyed as well. Exposure to flames, electrical or chemical burns can all lead to this type of burn. Next slide. So full thickness burn, the characteristic, there's no remaining viable dermis. So the zone of necrosis is now deeper. Versus in the first degree, the zone of necrosis is just on the upper part, right? Next slide. All right, I'm not sure if you can see this very clearly, but it's showing you, an injury, and the injury is deeper. Next slide. All right, so now we need to calculate the the body surface area. So how do we know how much burn the client has suffered? All right, how do we know how much burn the client had suffered? Next slide. All right, so we usually try to estimate how much burn the patient has suffered by using some tools. One of the most quick and easy way to estimate, like medium to large burns in adults is called the rule of nines, right? So here, what is happening is that the body is being divided into areas of 9%. Okay, and then in total burn area can be calculated in that way. All right, so the rule of 9 is a very quick method, but a more accurate method is the Lund and Browder chart, right? It is better because it tries to compensate for the variation in the body shape with age, and therefore can give you a better assessment of the burn area, especially in the children. Okay, so there's two ways: the rule of 9, which is very quick, or the Lund, which is more accurate, right? Which is more accurate, but it takes more time. Next slide. So this is a Lund method, and see how it's taken. When you look at the infant, the head is bigger, right? Whereas in the adults, that's not the same. So for the the chart we're looking at right now, for 0 to 1 years of age, the head, the percentage of burn is 19. So then you tell, if it's a child, so 19 is going to be bigger than the adult head, right? So look at 19% for the adult, for the head, and the adult is only 7%. See the difference? Because it takes into consideration the shape of their body versus just generalized percentage. Next slide. So the rule of 9, like I said, is very easy. It says that the head and the neck is 9%, right? Each upper extremity, 9%. Each lower extremity, 18%. Anterior trunk, 18%. Posterior trunk, 18%. Genitalia, 1%. So it's not as specific. And it doesn't take into consideration the shape in proportion to the rest of the body. All right, next slide. So this is the rule of 9. So see, the head is 9%, the neck is 9%, right? So the front of the head and the back of the head together makes 9%. So your trunk was 18%, right? So the front is 9, the back is 9. All right, so you add them all up. So when you're trying to calculate how much burn area, you're just going to add up all those areas to make one. The arm, front is 9, front is 4.5, back is 4.5, together makes 9. The leg, front is 9, back is 9, together makes 18. So it's pretty simple calculation. That's why it's used, because it's easy and fast. Next slide. So now we're going to talk about the vascular changes resulting from burn injury. Yeah, so there are some changes that result, right? So there is a systemic response to burn. Right after someone burns, there's some things that happens. It could be metabolic, cardiac, renal, blood, immune, the lungs, the GI, and of course there's edema and there's infection. So let's talk about the metabolic response. What you see here is like the histamine, the kinase, the thromboxane, serotonin, catecholamine. There is oxygen, free radicals. There's vaso-inflammatory mediators. All these responses, this metabolic response, are activated. right? When there's a burn. And usually when the burn is greater than 30% of the total body surface area, right? So histamine, that's responsible for like the increase in intravascular permeability, and it's usually seen immediately after the burn. All right, and it's released from the mast cells in thermal injury. And it's usually a transient type of, it works transient, like it's not like continuous. And then you have prostaglandin, and you know that prostaglandin, and that's prostaglandins, they are potent vasoconstrictor, vasoactive, right? And these are released from the burn tissue and the inflammatory cells. All right? So because of that, the edema is amplified. And then you have the thromboxane, thromboxane, and these are produced locally in the burn wound by the platelets. And these are also potent vasoconstrictors, right? So they decrease the blood flow under the burn, right? So the point is to try to alter the systemic production. And then the kinase, KININS, right? These are local mediator for inflammation that increase the venular permeability. That's VENULAR, permeability. And then you have serotonin, which is a smooth muscle contractor of the large blood vessel. And the point is to try to decrease the peripheral vascular resistance after the burn. And then you have, of course, catecholamine, that's CATECHOLAMINES, and they cause vasoconstriction as well. They try to reduce the capillary pressure. Its benefits is just to reduce the edema. And then you have oxygen radicals. And this is the most potent and damaging of the three because it plays an important role in all of the types of shock. High dose of it, antioxidant, vitamin C, have been found, to reduce the fluid need in burn patient. So all these things is happening. And then you have platelets that aggregate, which tries to increase capillary permeability. And then you have angiotensin II and vasopressin. Again, this is the systemic response when someone is burned. And these things try to participate in the normal regulation of the extracellular fluid by trying to control the sodium balance and osmolality through the renal function and thirst. And you know that angiotensin II is responsible for the selective gut and mucosal ischemia that happens, which causes the translocation of the endotoxin and bacteria. And then you have corticotropin releasing factor. They reduce the protein extravasation and edema in the burn patient. And of course, the cardiac system is also involved here because the cardiac output is going to be decreased, right? And it's usually decreased because there's decreased preload induced by the fluid shift, right? And the cardiac output, however, is going to be normal within 12 to 18 hours with successful resuscitation. So if we do a good job, then it will be, normal. renal blood flow is another issue. So the renal blood flow and the GFR, they decrease soon after an injury, right? Well, why would they be lower, their function? Well, because of hypovolemia, because of the decrease in cardiac output, because of this elevated systemic vascular. So you see oliguria and antidiuretic develops during the first 12 to 24 hours. And then it's followed by usually modest diuresis as the capillary leaks seal. And of course, the blood is also affected here. So the red cells mass decreases due to the direct loss. So they're losing blood. So immediately 1 to 2 hours after and delayed 2 to 7 days post burn. And you see hemolysis, right? Because of the damage to the cells and the increased fragile blood cells. And you see anemia in 4 to 7 days. It's usually common. And it usually persists until healing occurs. And of course, the immune system also is involved, right? Because the skin is a mechanical barrier, and now that is destroyed. So as a result, the immunoglobulin levels also decrease as part of the general leak and leukocyte chemotoxis and cytotoxic activity. So because of all these changes, together with the non-perfused bacterial colonized eschar, so eschar will form, which put the patient at risk for infection. Edema is also going to be affected. You're going to see edema because of the increased tissue, increased permeability of the entire vascular tree, and the loss of water, electrolytes, and protein from the vascular compartment. And you see severe hemoconcentration, right? It looks like they're not, they're concentrated, the blood is concentrated, but they're really not. The protein is going to leak, causing protein, low level of protein in the blood. And then of course the GI tract is also affected here. So there's a lot of stuff that is happening. All right, next slide. All right, so just to repeat, there's a shift of fluid, right? Occurs again after initial vasoconstriction, then dilation. The blood vessel dilate and the leak fluid into the intestinal interstitial space. This is known as third spacing. All right. Causes decreased blood volume and blood pressure. And again, occurs within the first 12 hours after burn. And this is why it's important for us to replace the fluid loss. Next slide. So again, fluid imbalances occurs as a result of the shift. So there's hypovolemia, there's metabolic acidosis, hyperkalemia, hyponatremia, and again, there's hemoconcentration. Next slide. So now the fluid tries to remobilize, and usually after 24 hours, capillary leak stops. The diuretic state, as we talked about, blood pressure increases. So remember, you've lost the electrolyte, so now you'll see hypokalemia. Next slide. So you have, remember, also the gut. So there's the gut gets paralyzed. When it paralyzes, you have something called Kerlan's ulcer. So acute ulceration, usually within 24 hours after the burn, because the blood flow, GI blood flow and mucosal damage stops it, paralyzed, paralytic ileus, right? So we usually treat these guys with H blockers or mucoprotectant and start food early. And of course, watch for drop in hemoglobin because you want to be concerned if there's bleeding. Next slide. So there are some phases of the burn. All right, there are phases of burn: emergent, acute, and rehabilitation. Right, emergent, acute, and rehabilitation. Let's talk about each one of these. Next slide. So the emergent phase, all right, this is usually seen immediately. Immediate problem is fluid loss, right? Edema, reduced blood flow, exactly what we talked about, those responses that you see. Fluid and electrolyte shift. The goal is to really try to secure airway, especially if the burn involves the head and chest. Support circulations by fluid replacement. Keep the client comfortable with analgesics, especially for that first and second degree. Prevent infection through wound care. Maintain the body temperature, and provide emotional support. Next slide. All right, so the knowledge of circumstances surrounding the burn injury we should know. Obtaining the pre-admission or pre-burn weight is really important, the dry weight, because we need to be able to calculate the fluid rate. Calculation is based on the weight obtained after the fluid replacement is started, not accurate because of the water-induced weight gain. That is true. So the dry weight is what we want. The height is important because we need to be able to determine the body surface area. And it's also going to help us to calculate the nutritional needs. We have to know the health history. Hopefully, if they're not able to speak, then we hopefully have the other family member, because their existing medical condition, their current health status or diseases can impact the recovery, such as diabetes. Right? Next slide. So what are some of the clinical manifestations that you will see with the emergent phase? Right? So clients with major burn injuries with inhalation injury are at risk for respiratory problems. It makes sense. Right? And usually, inhalation injuries are present in 20 to 50% of the clients admitted to the burn center, because usually it's an extensive, in order for them to attend, to be admitted, hospitalization is third degree, deeper or larger surface body area. So we need to make sure that we assess the respiratory system. You're going to inspect, the areas that are adjusted, that will show you signs of impairment in respiratory system, including the mouth, the nose, the pharynx, right? So you're looking at the lips, the face, the eyelashes, the ears, the eyelids, the brows, the lashes are strong indication that some type of inhalation injury may be present. Also look at their change in respiratory pattern, right? It may tell us something with the lung. All right, the client may become progressively hoarse, right? Develop a brassy cough. They drool or have difficulty swallowing. Produce expiratory sounds, wheezing, right? Crowning and stridor. So if there's upper airway edema and inhalation injury, you see, assess the trachea. Okay, and auscultate it for wheezing. If wheezing disappears, this indicates an impending airway obstruction, right? Because remember, airway wheezing means some air is going through. Complete an absence of wheezing, no air, right? Of course, if there's complete obstruction of airway, then you got to intubate. Okay, next slide. So other clinical manifestation, cardiac will begin immediately. Cardiovascular will begin immediately, which can, show signs of shock, right? So we need to, especially with electrical burns, we got to assess the cardiovascular system, EKG, monitor for edema, central and peripheral pulses, blood pressure, capillary refill. Remember when the picture, the nail bells were blue, pulse ox, really important. Next slide. So we need to make sure that we monitor the renal function, because the kidneys can have problem or fail, an acute kidney failure due to not intra-renal problems, but pre-renal stuff. So the cardiac, decrease in cardiac output, right? If there's decrease in cardiac output, there will be decrease in blood flow. So perfusion to the kidneys. All right, so urine is usually highly concentrated and has high specific gravity. Urine output is decreased during the first 24 hours. So we need to make sure that we are trying to resuscitate fluid and make sure that the urine output is at least 30 to 50 cc's an hour. Measure the BUN, creatinine level, and sodium level, right? So we want to know if the kidneys are failing. Next slide. Sympathetic stimulation during the emergent phase causes a reduced GI motility and paralysis. Paralysis, right? So the GI tract, there's paralysis. When it's paralysis, no movement. So if you listen to the bowel sounds, there's not going to be any bowel sounds. So auscultate. Monitor for signs and symptoms that there is paralysis, such as nausea, vomiting, distended abdomen. All right. So client with burns of 25% or more are intubated. Generally, they require an NG tube, so to help with the decompression, right? And which would in fact prevent aspiration, and would also help us, remove the secretion. Next slide. Skin assessment is really, really important, because the skin is burned. Other systems are important. I mean, there's respiratory involvement, remember ABC, right? So assess the skin to determine the size and the depth of burn injury. The size of injury is first estimated, right? Remember we talked about estimating using the rule of 9. A burn that involves 40% of the total body surface area is referred to as 40%. Okay, that's using the rule of 9. Next slide. So IV fluid, we have to replace the fluid. So we have to infuse IV, right, to maintain the cardiac output. Clients with burn involving 15 to 20% of the total body surface area will require IV fluid. So we want to prevent shock, right? Because we're trying to maintain adequate circulation. Severe burn requires large fluid loads in short time. That's correct. To maintain the blood flow to the vital organs. So decreased cardiac output will affect the perfusion to the other organs, the brain, the heart, the kidneys, the peripheral, just all the systems, the GI tract. All right, so the fluid replacement is calculated from the time of injury and not from the time of arrival. Diuresis should not be given, diuretics, right? Because we're not going to give them diuretic to increase the urine output. That's not why it's not because they have retention of fluid, right? Because diuretics do not increase cardiac output. They actually decrease circulating volume and cardiac output by pulling the fluid from circulating blood volume to enhance diuresis. Next slide. So common fluids that are used: albumin, protonate, albumin 5%, right? It's usually given in the first 8 hours. Lactated ringer without dextrose, half is given in the first 8 hours and then half in the next 16 hours. Crystallite hypertonic solution adjust to meet the urine output at least 30 cc, and crystalloid only, lactated ringer. All right, so that's what it ends up with. LR effusin, which has more other electrolyte compound. Next slide. So what are some of the nursing diagnoses that are associated with the emergent phase? So we're still in the emergent phase. Decreased cardiac output, makes sense, right? Fluid volume deficit related to fluid volume loss, ineffective tissue perfusion, ineffective breathing pattern. Dependent, it could also be impaired gas exchange, right? Next slide. Acute phase of burn injury. Right, so we're in the next stage. The first 24 hours is always important. So now we're in the next stage. So the last usually until the wound closure is complete. So our focus is to continue assessing and maintaining the cardiovascular and the respiratory system. And usually pneumonia is a concern from respiratory failure. And the general would need mechanical ventilation. We also need to make sure that we are protecting them from infection. So they have topical antibiotics. Tetanus, hopefully they've gotten the most recent vaccine. Weighing them, and we want to have a true weight, so we don't want to have a lot of dressing, on them, and then compare that result with a pre-burn weight. A 2% loss of body weight indicates a mild deficit, so it's not as significant, but a 10% or greater requires modification of their calorie intake. And of course, we want to monitor for signs of infection. Next slide. Okay, so for local and systemic signs of infection, from gram-negative bacteria includes, and those gram-negative bacteria are Pseudomonas fortis, which all of this infection can lead to septic shock, right? Septic shock and overwhelming infection. And usually from full partial thickness to full thickness injury. So you see ulceration of the healthy skin at the burn site. There's erythemas, there's nodular lesions, there's extensive burn, wound drainage, there's odor, there's sludging of the graft, altered level of consciousness, changes in vital signs, oliguria, GI disturbances, and metabolic acidosis. Next slide. All right, so what are the lab values? There may be hyponatremia or hypernatremia, hypokalemia or hyperkalemia, and of course the WBC will be higher to show infection. Next slide. Here are some nursing diagnoses for the acute phase. Impaired skin integrity, right? Because remember, acute is not as emergent. So when you ask a question about that, make sure you are understanding that acute is the most pressing, so airway, breathing, circulation, right? And then emergent is airway, breathing, circulation. Acute, you're looking at other things like their skin is impaired. That's important, but not as important as airway, right? Risk for infection, imbalanced nutrition, impaired physical mobility, and disturbed body image, right? Next slide. So some planning and implementation. So there's non-surgical management, right? No surgery, but we can remove exudate in necrotic tissue. We're going to clean the area. We're going to stimulate, granulation and revascularization and apply dressing, and debridement may be needed for these guys. All right, so non-surgical management. Next slide. So dressing the wound. So after the burn, of course, we have to clean it, We have to debride, we have to use topical antibiotic and reapply to prevent infection. That's what we do. And then the standard wound dressings are multiple layers of gauze applied over the topical agent. Right? Next slide. The rehabilitation phase is the last phase of burn, and it starts at the time of admission, right? So we start thinking about rehabilitation when they admitted, right? When they admitted. So we have to start considering psychosocial support. We need to start thinking about their home environment, financial resources, medical equipment, prosthetic rehab, and it's a lot of teaching about signs and symptoms of infection, drug regimen, when to follow up, comfort measures to reduce pruritus, right? Pruritus. Next slide. So diet, initially we don't give them any food because maybe the GI will be paralyzed anyway. But we begin oral fluid as soon as the bowel sounds return to ensure that they can tolerate it. We do not give ice chips or free water because it can lead to electrolyte imbalance. High protein, high calorie. Protein is good because it's going to build and repair them, right? Next slide. So what are the goals? Well, the goal is to prevent complication, which is a lot of them. Vital signs, assessing respiratory function, make sure that they have the tetanus booster, anti-infective drugs, analgesics, try not to give them aspirin, strict sepsis, and turning them to prevent contractures and emotional support. Okay, emotional support. Next slide. So debridement is done with forceps, curved scissors, or through hydrotherapy, so which means application of water for treatment. We only want to we're trying to remove the eschar. Blisters are left alone, right, to serve as a protective, right? We don't try to rupture the blister, all right? Next slide. Skin graft, it's done during the acute phase, and it's used for full thickness and deep partial thickness wounds, right? So find an area to donate. If they don't have any, then we can use other things. Next slide. So post-care for skin graft is maintaining dressing using aseptic technique. Graft should look pink, right? It should look pink if it has been taken after 5 days. Skeleton traction may be used, right, to prevent contractures. Elastic bandage may be applied for 6 months to 1 year to prevent hypertrophy and scarring, right? Okay, so it's really important for us to prevent contractures. So a lot of physical therapy, a lot of range of motion with these guys, scarring, extensive scarring, some body image disturbance. Really difficult for these guys. Really a difficult time for these guys. Let me just do a summary of pretty much what we just talked about the pathophysiology of burn and complication of burn. So there are some complications here. When someone is burned, there's usually shock. There's pulmonary complications due to the inhalation injury. There's acute renal failure, infection and sepsis, Kurlan's ulcer in large burns over 30%, usually after 9 days. Extensive and disability in terms of scarring, psychological trauma. It's really important. Sepsis, you have the bacteria that is present in the bloodstream, without clinical manifestation, it could be really terrible. So usually the cause of death for clients with shock is hypovolemia, renal failure, pulmonary edema, and acute respiratory distress syndrome, which will lead to multiple organ failure. This ends our lecture for burns. Thank you.